Doctors, we are live. You can start the session.
Okay, thank you. Respected past President Dr. Mohan Rajan and President-elect Dr. Nirmal and my dear Secretary Dr. Sriram Kobar and other office bearers of Tamil Nadu Ophthalmic Association, dear faculty, panelists and friends. Good evening to all of you. On behalf of Tamil Nadu Ophthalmic Association, it gives immense pleasure to welcome all of you for this wonderful webinar on diabetes and eye. You know, Tamil Nadu Ophthalmic Association is one of the forerunner in our country, which is doing so much of academic and other activities. And also, the past 2 years, not more than 2 years, is we have done so much of work in the field of ophthalmic education, not only for the postgraduates and fellows, and also for practicing ophthalmologists and also for other paramedics, etc. So in that way, today we have organized this meeting. And of course, all of you know very well the theme for the year, TNO theme for the year is Synergy through Unity. That is, together we can. That's a theme. And today being 14th November, World Diabetes Day, all over the world they are, I can say, celebrating or observing whatever maybe, you know, so World Diabetes Day is being observed throughout the world. So in our country, in our state also, so much of activities are going on to educate and also to make awareness about the diabetes and also the diabetes related complications. Because nowadays, because we people may be seeing more case of diabetes related complications, especially related to retina, glaucoma, neuro-ophthalmology, cornea, etc. So the theme for the current year of World Diabetes Federation for Diabetes is the education to protect tomorrow, because this is a very strong word where we have to protect the tomorrow, our the coming years. You know, otherwise we will be losing so much of things because of diabetes every day, and there are so much of complications due to diabetes, either not only eye, in general, there are so much of nephropathy, so much of renal transplantation, cardiovascular diseases, and stroke, and also amputations, and so much of things is going on. Even last year, there are about 61 lakh deaths due to diabetes. And the current year statistics, according to WHO, says that more than 60 crores of people are having diabetes, and it is very, very yes.
There is some echo. I'm not sure whether other people are getting it.
All of us are getting it, sir.
Huh?
Yes, King.
Yeah, all of us are getting that one. His
Echo.
noise is there.
Echo noise from you, sir. Ramakrishnan, sir.
Okay. Just a minute.
Is there any other instrument nearby, sir? Somebody has logged in?
Doctor, that's the issue with the mic, doctor.
Mic, is it? Okay.
Okay, sir. Now you unmute yourself. You have muted yourself, sir.
Okay, yeah. Yeah, it's okay now, or still echo is there?
Still there.
Still there. Yeah. No problem, sir. Please continue.
Okay, thank you. Okay, so today, as I mentioned, we have organized this webinar, and of course, we are having a wonderful speaker and a panelist for today's meeting, and you have to thank all the panelists who have graciously accepted their to participate in this webinar. Dr. Rajiv Raman, Dr. Sriram Gopal, Dr. Naveen Jayakumar, Sharmila, and Nirmal, and of course the speakers, my dear friend Mohan Rajan, Anandi, and Anand Rajendran, Ashish Sharma, and Syed Mohideen, and of course a debate, Dr. Deepak and Thandaras. I have to thank my dear Kim also for coordinating this webinar. From the beginning, he was very much instrumental in coordinating all the topics and speakers. And really, it's a wonderful set of speakers for today webinar. Definitely, it will be useful for all of us to update our knowledge in the field of diabetes, because diabetes is a ocean. Just we have taken just a small portion of that only. But anyway, it is very much useful for our day-to-day practice, so that we can give better care for our patients. With these few words, I will welcome our Nirmal to say few words, President-elect, and also the past President, Dr. Mohan Rajan, to say few words, and then I will hand over the mic to the podium to Dr. Kim and Dr. Rajiv. Dr. Nirmal.
Am I audible? Thank you, President. So, respected President, Dr. Mohan Rajan, past President, and all the office bearers of TNOA, and the experienced and expert panelists, faculty members, and TNOA members, and all the delegates seeing us on the various online platforms. Thank you for joining this World Diabetes Day Education to Protect Tomorrow program. President has initiated such a wonderful series of educational program on various international days, and today happened to be the World Diabetes Day. In fact, November is being observed as Diabetes Awareness Month world over because of this, and happy to see that there's a lot of public awareness and initiatives, not only from the medical fraternity, but also from the other stakeholders who are dealing with this dreaded disease. So diabetes, of course, is taking huge proportions and also bringing us unholy name, that being a diabetic capital of the world. So somewhere as medical professionals, we have to pitch in and work with the other stakeholders to reduce the incidence and also the complications. So there are various initiatives that will come. Even now, AOS has released a mail stating or requesting all the members to participate in the various initiatives. I'm sure members from TNOA and Tamil Nadu will also join in huge numbers and take part in the social initiatives. So once again, welcome all of you for this program. I'm sure this expert panel, the discussions and deliberation will be eye-opener for many of us and will give some new insight into management of diabetes. Thank you. Over to you, Dr. Mohan Rajan, sir.
Thank you very much, sir, and respected President, and all other esteemed members of the TNOA, Dr. Kim and the panelists and speakers. And it's really a pleasure to be here on this wonderful day, a World Diabetes Day. Let me compliment the President for taking the TNOA to a totally different level altogether this year. And when I introduced him as a Basha of TNOA, everybody said underestimated the thing, but he really has taken that TNOA to a totally different level. And since August, I think it's only about 3 or 4 months since he took over. And so many programs have come up for the sake of ophthalmic education. Ladies and gentlemen, I think you should take it from me that I think TNOA is the most active state association in the entire country as far as the academic activities are concerned. And we have to give credit to all the office bearers, all the members of the TNOA, all the faculty, all the institutions of the TNOA. And the top institutions are here in Tamil Nadu, and that is the reason we started the TNOA Connect series also last year. I'm glad that Dr. Ramakrishnan, the current president, is taking over, and he took off at a tangent, and he has taken it to a totally different height altogether. And this World Diabetes Day is very, very important. Every year we are doing this, creating awareness. The awareness is much better, but it is not good enough. But we need to create awareness among the physicians, among the patients, among the ophthalmologists, among the general ophthalmologists, among the public. Check up every 6 months or a year for patients to avoid blindness due to diabetic retinopathy. And I'm very, very thankful to TNOA for giving this wonderful opportunity to me. Thank you.
Thank you, Kim. It's up to you. The floor is yours.
Thank you, sir. Thank you, President, for giving us this opportunity in this most important, to talk about the most important condition. As you all know, have to talk more about diabetic retinopathy. But just to say, it is no more the domain of just the retina specialist, but every single ophthalmologist is responsible for managing diabetic retinopathy. And so the whole idea of having today's webinar is focused on how general ophthalmologists, or what should general ophthalmologists should know about the management of diabetic retinopathy, because almost 80% of all the diabetic retinopathy could be managed by everybody except for those 20% which needs that exclusive treatment like surgeries or few decision-making situations in the severe cases. So that's the whole idea. So in the interest of time, I don't want to, we can have the discussions based on the time that's available. But today I want to thank everybody who is participating in this. Every one of you readily agreed the moment I asked, we requested for this talk without a hesitation. So I want to thank you for sharing your thoughts about this subject on the most important topic of diabetic retinopathy. So without much ado, I'll request Dr. Mohan Rajan. No, needs no introduction to this audience, and I couldn't other than him to speak about the two topics that's in diabetic patients. Over to you. Just one more instruction on this is that I request all the speakers to stick on so that we will be having enough time for discussions at the end of each talk as much as possible, and then if time permits toward the end of the meeting.
So, are you able to see my slides, sir?
Yes, sir.
You able to hear me?
Yes, sir.
Very
Okay,
well.
thank you very much, Kim, for this wonderful opportunity. The president also, and I will be talking in the next 8 minutes about cataract surgery in diabetic patients. Me, this is my financial interest. As you know, this is the golden triangle: the retinopathy, nephropathy, and the neuropathy in diabetes mellitus patients. Diabetes mellitus influences the function and morphology of the eye lens. The cataract is the second most common complication of diabetes mellitus on the eye. Age of the patient, the duration and severity of the retinopathy, high HbA1c levels associated with hypertension, renal disease, smoking, multiple PRP treatments for PDR, and posterior, that is pars plana vitrectomy for vitreous hemorrhage or TRD. These are the risk factors as far as the cataract in diabetic retinopathy in diabetes patients are concerned. You all know this pathophysiology: the glucose aldose reductase pathway, the sorbitol, the lens swelling which occurs, which causes the typical vacuoles on the posterior subcapsular area, which is the posterior subcapsular cataract, which is very typical of the diabetic cataracts. These are different types of cataracts you can get in diabetic retinopathy in diabetes mellitus patients, like the PSC cataract, the cortical, the mixed cataract. The unique to diabetics is snowflake, but the most common we see in our clinical practice is the posterior subcapsular cataract, as you can see the picture on the left side, and the snowflake cataract on the right side as well. When you have a diabetic, this thing, always look at the back of the eye, because you may miss this. You can have a significant macular edema, you can have a PDR, you can have a vitreous hemorrhage as well. So preoperative is important that you minimize the worsening of the disease. Pan-retinal photocoagulation, focal laser photocoagulation, preoperative maximize results after or with the cataract surgery, perioperative injections, steroids, VEGF inhibitors. So the conventional thing is whether we can do SICS or ECC. I would prefer to do phacoemulsification because that produces very, very minimal damage to the blood aqueous barrier, which is again very important in patients who've got diabetes mellitus because the intraocular inflammation is much more. By 5.5 millimeter capsular excess, thorough hydrodissection, hydrodelineation, phacoemulsification, nucleus removal, divide and conquer, stop and chop, phaco chop techniques, whatever you are comfortable with. The machines are available. You have to combine the technology with the technique, irrigation, aspiration, making sure that you don't leave any cortical material, complete removal of the viscoelastic material, PC tear. If you have PC tear, make sure that you manage the PC tear very well with the triamcinolone and stain, and make sure that you do a good, adequate vitrectomy. What is the IOL selection? You can go in for a PMMA lens if the patient cannot afford, or a foldable hydrophobic acrylic lens. And this is very, very important because that's going to be the biologically the most inert, most compatible lenses, I would say, as far as diabetics are concerned. Size at least 6 millimeter optic, because you don't want that smaller size, because in future the patient requires a PRP or some laser for the posterior segment. Then you make sure that the optic is quite big as well. So I'm making a fairly big rhexis. You can see here the rhexis is about 5.5 millimeter, which is much bigger than what I normally do. And patients who got long-standing diabetes, and you can see the typical posterior subcapsular cataract. The rest of the cataract is like a just like a cakewalk, and you can see that I'm doing a direct chopping technique and going ahead and removing the cataract, making sure that I remove each and every cortex as well. If you have brown cataracts, it's not uncommon in patients who've got diabetics. Brown cataracts, the problem with the brown cataracts is that sometimes you can do ECC or SICS, but we do only phaco. But the problem is you can end up in a corneal edema, which is very, very common in patients who've got diabetes mellitus, especially when they have uncontrolled diabetes mellitus. And you can have a fibrin reaction, something like a TAS syndrome on the surface of the lens, which is also not very common, not uncommon. And of course, cystoid macular edema, which can occur in patients who've got corneal edema, as high as 25% of the patients who got diabetes mellitus as well. We have the femtocataract for these patients, which makes the life easier because the femtocataract uses less energy. In my hands, at least, you can see this is a fairly brown cataract in a diabetic, and I'm doing the femtocataract. The advantage of the femtocataract is that it goes on and it produces less energy, and there is less surgical time as well. And you can see that the amount of phaco energy which is there, the inflammatory mediators, everything is less, which actually is very good for a patient who got diabetes. You can see the clear corneas post-op, which is very, very typical. You need to make sure that you ensure, especially in a diabetic patient, because these patients are more prone for corneal edema. There is a problem in the corneal endothelium as well, and you can make sure that if these patients with the cold phaco technology in the conventional manual phaco, or with the catalyst or the femtophaco, you can consistently deliver clear corneas like this. If you have a posterior capsule rupture, okay, even in a normal patient is very important, but in a patient with diabetic, you need to make sure that you make sure that you anticipate and recognize this, and also make sure that you do a fairly good vitrectomy using tricot there, and then making sure that you don't have a drop any nucleus into the vitreous cavity, and making sure that you remove all the vitreous from the anterior chamber, remove the cortex and the epinucleus as well. So I'm just going to rush you through to some scenarios. Both eyes, mild cataract, the first scenario with the diabetic macular edema, preoperative vision 618. So don't be in a hurry to do a cataract surgery, because this can aggravate the diabetic retinopathy. Always stabilize the retina if you have a chance to do that. Intravitreal anti-VEGF with laser. 3 months later, you can do the cataract surgery. This is the OD picture, this is the OS picture. Post-laser anti-VEGF, stabilized, and then going ahead with the phaco with Avastin in this particular cases. So sometimes you need to combine the cataract surgery with the anti-VEGF injections or the steroid injections. In this particular case, I'm able to I'm giving a Avastin injection at the end of the surgery to take care of the macular edema. You can see the good recovery. Case 2 again, a PSC with a diabetic macular edema, preoperative vision 624, postoperative 66. I combine the cataract with the you can see the preoperative this thing, and combine the cataract with the intravitreal Osidex. Sometimes you can do that. So the combination therapy is also very important. You combine the cataract because the cataract is quite dense and you're not able to see the macula very well. So intraoperatively, you can see the macula, and you can have if OCTs, nowadays you have OCTs, you can penetrate, you can have a fairly good idea of what exactly the status of the macula is. And this patient also did very, very well. Okay, if the cataract is quite there, with the vitreous hemorrhage is there, and you need to combine the cataract with the vitrectomy. You can see this in the particular case wherein the preoperative vision is 660, postoperative after vitrectomy you can see 618 vision, and the patient is doing very well. So mature cataract with the diabetic macular edema in the other eye. So always what I do is I remove the mature cataract, have a look at this. This is the patient with the fellow eye. The right eye he had a mature cataract. We do not know the status of the macula, but right eye we know, left eye we know exactly what is the status of the macula and how much of macular thickness is there. So right eye also I see intraoperatively, and then go ahead and go remove the cataract and give an intravitreal Osidex for these patients as well. And small pupil it's a big problem in a patient with diabetes. They don't dilate as well, and it's another big problem. So you need to go and probably use iris hooks. In this particular case, there's a complicated cataract. You can see some membranes in the anterior on the anterior lens surface underneath the iris as well. Once you remove the membrane, the pupil dilates, but you need to dilate much more, and that's why you use iris hooks. And this is again very, very important, because in diabetics, the pupils are not very big. So especially with the older the patient, the longer the diabetes, there is a rigidity of the sphincter, and you can have this problem. Either you can go for a iris hook, or you can go for a BX ring, as you can see here, or you can go for a Maligun ring, whatever you are comfortable with. But all these, it is very important right in the beginning of the surgery, you do that, and making sure that you don't have any problem as well. Please understand these patients are all older patients. They're also on some anti-prostate agents like tamsulosin or Urimax or whatever it is, and they can have floppy iris as well, which can make the pupil much more smaller. So right in the beginning, you can end up in a problem like this. You can end up in iris trauma, and we can produce severe inflammation in a patient with diabetes. And you need to make sure that right in the beginning of the surgery, you take care of these patients in this thing. Again, cataract with the TRD, cataract membrane peeling and silicone oil injection was done. And you can see the cataract with the PDR, postoperative vision is about phaco plus vit. The problem with the phaco, with the vitreous hemorrhage is a big problem, because you don't have a good red reflex there. If you don't have a good reflex, it's very difficult to do a capsulorhexis, very difficult to do a phaco. So you need to go a little more blind technique. And you can see here, I'm trying to do that. I'm trying to make a slightly larger rhexis and trying to prolapse the nucleus into the anterior chamber. And because there's no red glow because of vitreous hemorrhage, and it makes the life a little more difficult. But there is what you call the trick, I would say. You can see the hemorrhage in the anterior chamber as well, and you can see absolutely no red glow at all. Very, very important for you to understand. Go by the anterior capsulorhexis margin and go accordingly. Stay close to the anterior capsulorhexis margin, which is very, very important for you to understand, so that you don't rupture the PC. Once you rupture the PC and the vitreous loss is there, the inflammation is much more in the diabetic. You should also understand that. So also visible PRP. If you have a cataract, try to do a visible PRP as much as possible, and then go ahead with the patient, because this PRP, which is saying, again, a patient with a vitrectomy already done with an oil there. I'm doing a phaco with an SOR. This is a very, very difficult scenario. If you have a cataract with a oil underneath, because there can be oil in the anterior chamber, there can be posterior syndicate, there can be a fibrotic anterior capsule, there can be a fibrotic posterior capsule, plaque on the posterior capsule. And I'm going ahead with the thing you can see here in this particular case, and I'm able to do a fairly good rhexis and remove the cataract, and you can see that oil droplets are there in the posterior capsule, and subsequently you put a lens and then go past plana and remove the oil as well. So the management of cataract with diabetic macular edema or diabetic retinopathy, you need to have a good straight concept as far as the phacoemulsification is concerned. The strict parameters are there. Combine that with the anti-VEGFs like Lucentis, Avastin, Eylea, or Tricot steroids like Tricot or Osidex. The timing of the surgery is very important. Phacoemulsification is the method of choice. Consistent surgery, clear corneas, hydrophobic IOL in the bag. Post-operative medication, be aggressive on your steroids and NSAIDs, because these patients are more prone for inflammation like the fibrin reaction or TAS or even CME post-operatively. Do a retinal examination consistently on a routine basis in the post-operative period. Minimal cataract, stabilize the retina, First injections and laser, dense cataract, combine the cataract surgery with intravitreal injections like Lucentis, as I told you, and then advanced diabetic retinopathy, you can do a phaco and a vitrectomy with membrane pilling, with or without oil or whatever it is. Thank you very much for the wonderful opportunity again.
Thank you, sir.
Thank you, sir.
Excellent presentation. And I think you brought in all the nuances of managing a cataract surgery in diabetic patients.
Yes.
Not specific to diabetic retinopathy, but diabetic patients. I think that is, you brought out all the important parts. But what is the single most important challenge that you would think of while doing, what everybody should be aware of while doing a cataract surgery in diabetic patients?
I think the most important thing, especially when you have patients who have suddenly brought the blood sugar down and you are taking about the patient for cataract surgery, be wary of endophthalmitis. Okay, you need to be very, very careful because these patients are all something like immunosuppressed patients. You have to be very, very careful. And if at all there is a wound which is leaking, if you have a suspicion, always put a suture. That's what I would say. So infection is one of the most important things you need to be careful, especially in a patient who's got a rapid down increase. 3 months back, he was about 12, HbA1c was 12. All of a sudden, it's come down to 7. And then you take him up for cataract surgery. And these patients are all very, especially when you have a complication, like a PCR, the infection, as you know, the endophthalmitis goes up by about 4 to 5 times. And you need to be very, very careful. I suggest that in these patients, diabetic patients, what I do is I follow them up very, very closely post-operatively. Very important.
Thank you, sir. I think that's a very, very important.
Okay, just one.
Intracameral antibiotic for all patients I use, irrespective of whether they are diabetics or not. Yeah. Yes, sir. Ramakrishnan.
No, just you mentioned about the during cataract surgery itself, you will be giving anti-VEGF, no?
Yes, sir.
Just I want to know about the opinion of retina other people.
I would request now Dr. Rajiv, who's the doyen of diabetic retinopathy.
Sir, nothing like doyen, but yes, what sir is telling is a concern that many times you want to give both together, especially if a patient, so preferably start with anti-VEGFs alone, anti-VEGF or steroid. And if during the course you feel the cataract is contributing to the vision loss, and as Dr. Mohan Rajan rightly said, that is a time we can combine both. We can do both cataract surgery along with anti-VEGF or a steroid injection. It can be done. That's not a problem. Usually we do it at the end of the cataract surgery. So at the end of the procedure, you can inject it. Only concerns which some of the people have that go again, that's something that if there is an infection or something, what caused it, we don't know.
Yeah.
Anti-VEGF or for the cataract surgery. But I would suggest if people are routinely giving intracameral antibiotics, it's good idea to after your injection, then do it. Then give it.
Rajiv, again, in the word of caution, it is not necessary to give just because a patient has any diabetic retinopathy, you start giving them the injection along with just as a prophylactic.
It's only when there is DME. It's only when there is DME. If there is no center involving DME, then it's only when presence of center involving DME is there.
Yeah.
So that is something where everybody should take note of. We should only in the presence of center involving diabetic macular edema.
And one of the things which you can probably do, because recently we showed that many of the cataract surgeons use the IOL master, and that also gives a small OCT at the, if you look carefully, you can actually pick up center involving DME. So
to a certain extent, it's not very clear, Rajiv, but
yes. We have proved it. It is about 90% accurate.
Yeah.
If there is, so especially you can, rather than looking at absolute thickness, look at presence of cysts there or any of the thing. You can easily make out that.
Yeah, IOL master 700 gives that. Yes, correct.
Yeah, so it gives very clearly. So even if you have not got a OCT done, it's good idea to look into your biometry very nicely. That can sometimes you can pick up that there is a center involving DME or not.
Yeah, because the IOL master 700, the rays go through the exact center of the fovea. So that is the advantage of getting that scan. And
That
I
one
fully agree.
monitor, center 1000 microns you get, and that is what we are interested in, center involving DM.
Any comments from the other panelists? Or
So do you do a pre-operative specular for all diabetic patients? Studies say that there might be a drop of 120 cells in the endothelial count in the
For
diabetic and non-diabetic.
all brown cataracts, what we call as cataract or rubra, anything above grade 3 or 4, I do a specular microscopy for all my patients. Whether it's diabetic or not, I do for all my patients. And we have not found a particular difference between the diabetics and this thing, but I think we should start looking at it in a little more prospective way, I would say. Yeah, but it's a good thing. But what I would say, because nowadays we have got excellent viscoelastics, like Viscoat, and even the Aurolab has got this Auro, am I right? It's all these, produce very, very less phaco heat energy in the anterior chamber. So it's a fairly safe surgery as long as you are able to do a perfectly posterior plane phacoemulsification. Very important. You need to make sure that your plane of phacoemulsification is right behind the iris in the posterior plane. Don't bring these lenses up into the anterior chamber, especially when you end up in a very bad macular edema. Sometimes it will take a long time to clear. And also because macular edema, as I told you, it is not only the macular edema might clear, but the problem is there can be inflammation in the eye. There can be cystoid macular edema in the back of the eye.
I have one question for Sriram. What is your
Yes,
threshold
Rajiv.
of doing a combined cataract vitreous surgery in diabetic vitrectomies? Because that is something many a time diabetic vitrectomies, you do have a bit of cataract. So
Yeah.
what is your threshold when you want to do both together?
Two criteria for that, Rajiv, actually. One is how dense the cataract is, and what type of cataract it is. Like, meaning if there's a PSC and a lot of membrane dissection to be done, I wouldn't like to face difficulty during surgery. And any nuclear sclerosis of grade 3 and above, I would choose to do combined surgery. Extensive cortical opacity is also, even though the central area is clear, for want of better view during dissection, I'll do a combined surgery. PSC, I will do combined surgery. And usually, if there is extensive membrane dissection to be done, it's actually a very dicey call. On one side, you don't want to do a combined surgery, so you increase the duration of an already long and prolonged surgery. But on the other side, it is always better to have a good view. So that, I think, it's a personal call. In those cases, especially if I'm injecting those cases before doing surgery, I would prefer to do the phaco and intravitreal combined, and then take them up for a vitreous surgery alone after 3-4 days. So it depends on both how complex a retinal surgery is and how dense the cataract is.
Thanks. I think what you told absolutely
And-
true. The threshold is gradually reducing now. And more important, what I've realized
Yeah,
is
very much.
complication happen only when visualization is bad. So I think
Exactly.
if another thing which I realized is because I don't do cataracts, I have a cataract surgeon who does it. So just make sure that, because the cornea, many times these are the cases you debride the epithelium at the end of by the time the major steps you are dissecting the membrane, it becomes bad. So I think if you know, the hydration of the port should be avoided.
Exactly.
Yeah.
So like Mohan Rajan sir said, a lot of times it makes sense to just put a suture if you're in doubt rather than hydrate the port and make the wound stay.
I put a suture always when I do a combined surgery, because when you put the trocar and cannula, I don't want any this thing on the wound. I don't want to hydrate the wound because that will make the cornea even more. Suppose hydration extends to the center, there'll be a problem in visualization. So,
And also the
time,
the axis in which you place the.
thank you, sir. Thank you very much, sir.
Sorry, sir.
Thank you, sir.
Yeah.
So
Yeah, many
now
topics.
call upon Dr. Mahesh Kumar, who is a well-known neuro-ophthalmologist, and none better than to speak about the cranial palsies and how do you manage in the diabetics. Over to you, Dr. Mahesh.
Thank you, sir. and I thank the TNOA for the opportunity given here. So I'll be speaking on cranial nerve palsies in diabetes. So when we talk of cranial nerve palsies, commonly what we think of is a 3, 4, and 6th cranial nerve palsies, which typically cause diplopia. But we should also not forget that 7th nerve palsy also can occur in diabetes. And more importantly, the second nerve is also a cranial nerve. And commonly we come across ischemic optic neuropathy as a complication of diabetes, such as in this case, you can see here, there is a pallid disc edema and the opposite eye showing a negligible cup disc ratio. And commonly we might see almost one case at least per day. I'm sure everyone will be seeing that because of diabetes and because of this prone anatomical structure where the Millian axons are tightly packed within and are prone for ischemia. So the other common oculomotor nerve palsies, which are more common in diabetes, are 3, 4, and 6th cranial nerves. So in general, we will be seeing all these, assess these cranial nerves in terms of clinical features, the anatomical site of lesions, and the possible etiology and the evaluation. So only after seeing the clinical features and ruling out other etiologies should we come to the conclusion of a diabetic cranial nerve palsy, because fundamentally the management of these conditions will differ. And if we erroneously label a cranial nerve palsy as due to diabetes, then we are likely to miss something major intracranially. So a careful evaluation is must before labeling it as a diabetic cranial nerve palsy. So we need to see whether it's an isolated nerve palsy or whether it is a multiple cranial nerve palsy. The moment it is multiple, it may not be a diabetic mononeuropathy. It could be we should rule out something else by neuroimaging, whether it is recurrent. And the history also should include whether what is the onset and the duration of the double vision, and whether there is pain or not. So contrary to belief, pain alone is not a differentiating features between diabetic cranial nerve palsy and other compressive cranial nerve palsy. Pain can be equally excruciating in a diabetic cranial nerve palsy, like a 3rd nerve palsy or a 6th nerve palsy or a 4th nerve, because of the profound ischemia. And so pain alone should not be a differentiating feature, ruling out diabetes. So mechanism in ischemic in diabetic cranial nerve palsies is that basically it's an ischemic mononeuropathy, not very different from what happens in elsewhere in the body, like retinopathy or in the heart or the kidney or in the brain. So what are the points to be considered in a 3rd nerve palsy? We need to see whether the pupil is involved or spared. It's the most important point. Is the palsy complete or incomplete? If the palsy is incomplete, we need to rule out other causes and whether there are any signs of aberrant regeneration. Aberrant regeneration occurs whenever there is a structural damage to the 3rd cranial nerve. And in a diabetic nerve palsy, there is no structural damage. It's only a functional damage because of the ischemia. And so the moment we see an aberrant regeneration, do not diagnose it as a diabetic cranial nerve, a diabetic 3rd nerve palsy. So the classic clinical features are ptosis, and there is an abducted eye because of the paralysis of adduction, and there is restriction of elevation and depression. We need to make sure that the intorsion is present, meaning that 4th nerve is intact, because the moment you can see the pterygium getting buried in the lower lid, lower palpebra. So the meaning that the moment the 4th nerve is also involved, we need to consider this as a multiple cranial nerve palsy, and we need to neuroimage and not just label it as a diabetic 3rd nerve palsy. And the point of contention is the pupil. A well-reacting brisk pupil is essential to make a diagnosis of a diabetic 3rd nerve palsy. And why is this so? Because pupil fibers are spared in a diabetic nerve palsy, where the vasa nervorum alone is affected in diabetes, whereas pupil fibers are supplied by the pile plexus, which are damaged by external fibers. So the moment the pupil is spared, we can be safe. But if the pupil is dilated, mid-dilated, or sluggish for any reason, even if it is not fully dilated, if it is sluggishly reacting, then we need to consider this as a pupil involved 3rd nerve palsy, and we should not diagnose diabetic 3rd nerve palsies. Similarly, fourth nerve also can be potentially involved in uncontrolled diabetes. So a point I would like to make here is, don't expect blood sugar to be high at the time of examination. The typical history is 10 days back, I had a high blood sugar and it has been well controlled now. So this is the point which we need to understand. A rapidly controlled diabetes can potentially give rise to all these nerve palsies. So they might have had a high blood sugar, and an aggressive management of the diabetes, a sudden control, can precipitate all these diabetic mononeuropathies like third, fourth, and sixth nerve palsies. So similarly, a fourth nerve, we need to look at the head tilt and the chin depressions. We need to look at the hypertrophy and the involved eye and the head tilt to the opposite side and face turn to the opposite side. And you can see the restriction of depression in adduction, which is the site of action of the fourth nerve. Also, do not forget to look at the extorsion of the eye. Because of lack of intorsion, there is extorsion. So it's best seen in a dilated indirect ophthalmoscopy. So in the case of sixth nerve, which is again not uncommonly due to diabetes, the primary position, the eye is adducted because of the abduction restriction. And like other cranial nerves, it can also be involved in a variety of conditions like tumors or demyelination or traumatic. But after ruling out all these other conditions, we can make a diagnosis of a diabetic sixth nerve palsy. In a sixth nerve, for example, in this case, the most important point is make sure we are not missing a raised intracranial pressure, because sixth nerve can be a false localizing sign in a raised intracranial pressure. And always look at the dilated fundus in case of a sixth nerve. In every case, we need to look for, but more so in a case of a sixth nerve, rule out a diabetic, because any raised intracranial pressure can give rise to sixth nerve palsy, not necessarily like a midline shift, like in this case, an extradural hematoma, but even an idiopathic intracranial hypertension, which is quite common nowadays, can also manifest to you as a diplopia and a sixth nerve palsy because of the raised intracranial pressure. A common symptom in many of these patients is, they may not say that they have double vision, but they will simply say they have a blurred vision, especially in case of a paresis, a mild cranial nerve palsy. They will simply say that they have a double vision. They will have a blurred vision. So when we do not know what is the cause of blurred vision, the vision may be 6/6, the fields may be normal. A simple question to ask them, and whenever the ocular movements are apparently full, a simple question to ask them is, do you see better when you close either eye? When you close one eye, and then when you close the other eye, the patient instantly says, yes, my single vision is better than both the eyes. Then what they mean actually by means of blurred vision is actually a double vision. That is a clue for us whenever there is a mild nerve palsies. So far we have seen about 3, 4, 6 combined the isolated cranial nerve palsies, which are common in diabetes, making sure that we are not missing other subtle other nerve palsies associated. So this case is a young lady, 45-year-old, which presented with a complete ptosis. And on examination of the extraocular movements, you can see there's an adduction limitation. Her abduction is also limited, and her elevations also are limited. All movements are limited. She's got total ophthalmoplegia, and note also that she has got some degree of chemosis and some degree of lid edema. So this is she's not a known diabetic. On fresh examination of blood sugar, she was a high diabetes. So this is not an uncommon presentation of patients to the ophthalmologist presenting with cranial nerve palsies. And many times we are the first person to detect diabetes in these patients. Remember, check the blood sugar in all these patients. They may not be aware of it. And in this particular patient, what the patient had was actually a filling defect in the cavernous sinus. He had a dilated superior ophthalmic vein, and you can see the dilated superior ophthalmic vein. And this is a case of a cavernous sinus thrombosis because of uncontrolled diabetes manifesting as a combined cranial nerve palsies. So usually cavernous sinus thrombosis require high dose of antibiotics or systemic antifungals. And we are all aware of the mucor which presented during the COVID times, and it requires the care of an internist for a thorough checkup. And always in suspected mucor, try to look at the palate. And for example, in this case, this photo is given by the ENT surgeon. We could see the necrotic palate and the debrided necrotic palate. this will give us a clue for the mucor. So when do we consider neuroimaging in oculomotor nerve palsy? Whenever, as we said, whenever it is a combined nerve palsy, more than one cranial nerve palsy is involved, it's not due to diabetes. So we need to have a careful examination. And whenever they have brainstem features, like difficulty in walking or other brainstem features, whenever there's a multiple nerve palsy, whenever there is a papilledema, always look at the fundus. Whenever the cranial nerve palsies are not resolving more than 3 months, in spite of good control of diabetes, we can always tell the patient it may take 4 to 8 weeks. But if it doesn't resolve beyond 3 months, consider neuroimaging. And isolated third nerve palsy, even if it is a pupil sparing with aberrant regeneration, always consider a cranial nerve palsy. So in practical situations, any third nerve palsy require neuroimaging as early as possible, and even a sixth nerve palsy may require earlier neuroimaging. Thank you for your kind attention.
Thank you, Dr. Mahesh. It was excellent. I think you gave all the tips how we can manage these nerve palsies. And I was about to ask the question which you had put in the last slide, when to do the imaging. I think that is something. And I would again ask you when not to do imaging. That is also very important. There is only 1 or 2 conditions where you don't want to do imaging, don't want MRI, just okay, watch for 3 months. Which would be those palsies?
As actually speaking strictly, there is no strict contraindication for imaging except MRI whenever there are potential foreign bodies, metallic foreign bodies. We do not want to do MRI. And whenever we need an emergent neuroimaging, for example, a patient presented with an acute third nerve palsy with pupillary involvement and acute headache, we do not want to wait for MRI to be done. We need an emergent neuroimaging like a CT scan to rule out an intracranial hemorrhage. Then we should not be waiting for an MRI because MRI takes time. And and also whenever there's an intracranial or intraorbital foreign body, apart from that, I think there is no strict contraindication for neuroimaging in today's situation.
Can I ask a question, Mahesh?
Yes, sir.
Rajiv,
Please, sir.
with when do you give steroids for these patients?
Steroids are best avoided at any cost. So we will not give steroids unless we have ruled out, unless the patient is young, there is no diabetes. And in case of diabetes,
I'm talking about diabetic palsies.
No steroids. No steroids.
Suppose after 4 to 6 weeks or 8 weeks, they don't improve at all.
No steroids. We will not give steroids. No steroids.
Okay.
There's no role of steroids in these
No
cases.
role of steroids.
Maybe we can consider Botox to the medial rectus. That's a separate chapter by itself. In case sixth nerve is not resolving, but no steroids.
Dr. Mahesh, how do you generally manage these isolated nerve palsies?
If we are very sure that the cranial nerve is strictly isolated, then we tell the patient to control if, especially the blood sugars are high, recent blood sugars are high, HbA1c is high. We can take calculated risk in not doing a neuroimaging, and if the patient will follow up within 4 weeks or 6 weeks, and if the patient understands. However, if the patient, if we are not sure about the follow-up with the patient, it's better to do neuroimaging even if there is a high blood sugar. So it's a relative indication, relative call. It's a relative call, but typically we follow them after 4 to 6 weeks and decide on the course of the nerve palsies.
Okay. Ophthalm-wise, we hardly have anything to give other than occluder and supportive therapy.
Supportive medicine.
So what are the neurosupportive measures? Generally, we see multiple drugs being given, either amino acids, multivitamins, or neurosupportive medications, pregabalin, and so on. So what exactly is the scientific rationale in giving so many drugs, or is there any rationale at all?
So we would better give probably only one neurovitamins, and there is another. In some situations, we can give pregabalin, especially because if there is a severe neuropathic pain, as we discussed in a cranial nerve palsy, there is sometimes severe pain. we can probably give neuropregabalin combinations. Some patients feel comfortable with that.
Any role of aspirin?
Aspirin, there is no direct role unless they have a coexistent morbidities
Okay.
like other situations.
Just one little basic question, Dr. Mahesh, like, do you feel like for diabetic retinopathy, you have some risk factors like duration of diabetes, glycemic control? For cranial nerve palsies in diabetics, do you have any specific risk factor besides the glycemic control?
There is no identifiable specific risk factor except when an advancing age. So we have seen that many patients say that 10 years back also I had this same amount of blood sugar. I did not develop all these things. So probably in advancing age, they are more prone, and coexistent risk factors like a hyperlipidemia may contribute, and high blood sugars. Apart from that, there is no specific risk factor, I would say.
Thank you.
Yes, usually how long it will take for this thing to get resolved?
The time we give for the patients is 6 to 8 weeks, and many patients resolve within 4 weeks. Sometimes by 3 months also, if they have a poor diabetes control, we have seen patients even up to 3 months, they don't resolve. So it's because of pure diabetes control.
I think we'll go to the next talk. Anybody has any points to add? I think
What about coexistent tuberculosis? I've seen recurrent nerve palsies in diabetics, when we investigated for tuberculosis, we found out that they got tuberculosis as well. When they have recurrent nerve palsies, for example, every 3 months or 6 months, they come out with the third nerve, then fourth nerve, sixth nerve, then in diabetics. So tuberculosis is, do you think it's important to rule out?
Probably yes, sir. Any immunocompromised status in that situation, they may have recurrent nerve palsies. Occasionally we do see them. Probably we'll have to rule out immunocompromised status like tuberculosis also, yes.
But it's not a cause and effect problem, is it? When you say tuberculosis.
No, sir. It may not be a direct causative effect.
Yeah.
So we'll go to the
Thank
next
you.
talk.
Thank you.
We'll go
Thank
to
you,
the
sir.
next talk, and I'll request Dr. Anandi to talk about how I manage my case of diabetic macular edema. Dr. Anandi, please.
Very good evening, all of you. And I thank the organizers for having given me this opportunity.
And you have to share your slides.
Yeah. The slide, is a slide visible, sir?
No.
Not yet, sir. One second.
Mahesh, நீங்க okay close பண்ணுங்க. Mahesh Kumar. Yes.
Mahesh has to stop sharing.
Okay, you have to stop.
Stop, sir.
You're able to see that share screen, madam. You're getting the, is it open?
Yeah. 1 second. Share, yeah.
Yes.
Have I shared my screen?
Yes,
Now
yes.
it's
You can go to the
Yeah.
first slide. Can make it full screen, ma'am.
Full screen.
Full
Down
screen.
you have that.
Is it now full screen?
No, not it.
It's not full screen.
Slideshow you have to.
One second. Screen share out,
No. Okay.
Doctor, I mean, do you see full screen on your system?
Full screen.
Okay, I think so. Yeah, whatever you're trying to do is correct. You go to the slideshow menu on the top.
Yeah, I did. And
No, in the bottom, at least those three, whatever that,
one second.
Her mouse is not visible. Probably whatever she's seeing on the screen, we are not seeing that, doctor.
Yeah.
Do you have two screens, madam, or only single screen?
Only one screen, sir. 1 sec.
You should be able to.
ஸ்கிரீனே தெரியலன்னு சொல்றேன். ஸ்கிரீன்ல
Madam, very simple, madam. Very simple. இப்போ stop screen பண்ணிடுங்க. Stop share பண்ணிடுங்க, madam.
1 sec.
Yeah. Okay, இப்போ வந்து நீங்க full screen பண்ணிடுங்க. PPT open பண்ணி full screen பண்ணிட்டு
Yeah.
press the alt tab, go to Zoom. அப்ப share screen பண்றீங்க இல்லீங்களா? அப்ப வந்து அந்த thumbnailல நீங்க எந்த screen-அ full screen பண்ணிருக்கீங்களோ அதை share பண்ணுங்க.
Okay.
That's more complicated, you have told. Correct. No, I would get more confused. The first thing is okay, but that alt thing, she'll get confused. Definitely, I'll also get confused.
Typical technical response from the IT person.
Yes.
It's a complex VR surgery.
Share. Yeah. Has it come over, sir?
Not yet. Just press that slideshow, madam.
Yeah. Still, it's not full screen.
It will happen now. You have pressed it, no?
Yeah.
No, that's what, doctor. What happens is she might be seeing the full screen, but we will not be able to see the full screen.
Yeah.
Try pressing F5, ma'am.
You can
F5.
present it like this.
Resume
Okay.
slideshow.
Yeah.
Resume slideshow.
கீழே
1 sec. I'm sorry.
F5 போட்டாலும் ஸ்லைட் ஷோ வந்துரும் மேடம்.
எது ஒரு நிமிஷம்
அஞ்சு போடவா?
வர மாட்டேங்குது.
சரி பரவாயில்ல, இப்ப இதே வச்சு பேசுங்க அவ்வளவுதான்.
We can start
Just
without
go
that
ahead.
also. No
Yeah,
problem.
you can go ahead, Anandi. Yes.
What are you seeing, sir? Actually, I
We
can
can
see
see the
this,
screen. We can see your slide. Only
but it's
it is
not
full
full screen.
That's
Full
it, that's
screen
it.
மட்டும் இல்ல.
பரவாயில்ல, doesn't matter.
Slideshow போட்டா, I am seeing the full screen. So
I think madam can present like this only, I think.
Yeah. You can go ahead. Yes, yeah.
yeah.
Go ahead.
this-
Yeah, we are
okay,
far behind
okay.
the schedule.
Yeah, I know. Good evening, all of you. So we'll talk something about diabetic macular edema. So it's the most common cause of. Hope you can hear me.
Yes, yeah.
Very good.
Yeah. So this is the most common cause of vision defect in diabetic retinopathy, and the prevalence is estimated quite high at 7% of all diabetics. And in type 1 diabetics, the VSD are found by 25 years, 29% of patients develop DME. And we'll discuss the risk factors is the same as DR, that is the duration of diabetes and the diabetic control along with the metabolic control. And the pathogenesis we'll discuss. The natural history is like untreated DME. There is a moderate visual loss in about 3 years, about 24% of patients. And it can also undergo a spontaneous resolution or go for a persistent macular edema. That's the natural course. And of course, the prevention by the good glycemic and the metabolic control and proper screening. Now, the visual acuity against the central subfoveal thickness on OCT is just a moderate correlation. It's you cannot assess the visual acuity just by looking at the OCT. So it's about estimated that a 4.4 letter change occurs every 100 micron in the OCT, an increase or decrease. So we'll discuss about the examination and diagnosis. Just a short thing on the pathogenesis. It's the hyperglycemia which is at the center, and that gives rise to the advanced glycation end products in the endothelial cells as well as the pericytes. That along with the receptors for the AGE, it upregulates the adhesion molecules, and that also causes a reduction in the nitric oxide, and that leads to the elaboration of VEGF. So the hypoxia giving rise to the VEGF, which is right at the center of the inflammation as well as the vasogenic pathogenesis of diabetic macular edema. And there is a metabolic disruption of the blood retinal barriers, the inner blood retinal barrier being
Madam,
the.
are you moving the slides?
Your slide is not moving.
Am I in the pathogenesis slide, sir?
No, the second slide, only the second slide.
Only the second slide is visible. One
Yeah.
sec, sir. 1 sec, sir.
Yeah.
இதுல தெரியுதா அவளுக்கு தெரிய மாட்டேங்குது. Stop share பண்ணிட்டு I'll just get back, sir. See, now share screen photo. How do I share my
In the
PowerPoint?
interest of time, we will not have discussions in between the talks. We will
Yes,
have
sir.
towards the end.
Share screen போடுறோம். இதானே? இதுவா? Share கொடுத்துருமா? Now is the pathogenesis slide visible?
Yeah.
Yes.
Okay.
Yes, sir.
Okay. So I'm just talking about.
Now it's also in full
yeah.
screen.
Is in full screen?
Yes, sir. Yes.
Oh, thank you. So it is the VEGF, which is right at the center of both the vasogenic and the inflammatory component of the pathogenesis. It leads to disruption of the blood retinal barriers, the inner blood retinal barrier, which is formed by the vascular retinal capillary endothelial tight junctions, and the outer blood retinal barrier by the RPE. And there is an oxidative stress which is triggered by the AGE, which is the reactive oxygen species, that gives rise to the protein kinase C and the TGF beta, and that forms the inflammatory component. So all this put together leads to an intracellular edema in the neuronal and the Muller cells, and that which this component is reversible, then it becomes an extracellular edema, which is the definition of diabetic macular edema, but then it becomes a little irreversible, which has to be treated. So just look at the protective factors in the retina, which prevent the vasogenesis, angiogenesis, the main being the pigment epithelium derived factor from the RPE. And these are the various upregulated mediators, VEGF being the main one, of course, angiopoietin 2, osteopoietin, erythropoietin, endostatin, and angiostatin. These are the various mediators which have been indicated. So the VEGF upregulation is caused by, to make it very simple, is the hyperglycemia, AGEs, the pro-inflammatory cytokines, then the hypoxia giving rise to the hypoxia-induced factor 1 alpha, then the growth factors various, all these leading to a VEGF upregulation. There are two main effects of the VEGF upregulated, that is the breakdown of the blood retinal barrier giving rise to macular edema, and the angiogenesis giving rise to the proliferative diabetic retinopathy that forms the vision-threatening diabetic retinopathy. So that is in short about the pathogenesis. And when approaching a patient, we do a clinical diagnosis by a biomicroscopy with a non-contact fundus lens, 90D lens, and indirect ophthalmoscope. Look at the retinal thickening, locate where it is, and then classify it using the fundus fluorescein angiography and optical coherence tomography. And never forget the metabolic parameters like anemia, HbA1c to be maintained between 5.5 and 6.5, and the various metabolic parameters, including the serum lipids, the microalbumin to rule out nephropathy, and the blood pressure of the patient, which becomes the core to management of diabetic macular edema. By definition, diabetic macular edema is presence of extracellular fluid in the macula within 2 disc diameters from the center of the fovea. And ETDRS in 1980s has given the clinically significant macular edema with the 3 criteria. Then fundus fluorescein angiography, you can classify it as focal, diffuse, and ischemic, and that would decide the way we manage it. And now with the onset of anti-VEGFs, the ICO classification as center involving and non-center involving diabetic macular edema holds good. So by ETDRS, this clinically significant macular edema, the 3 criteria are that there's a thickening at or within 500 micron from the center of fovea. Then you have hard exudates within 500 micron from the center of fovea with an adjacent area of retinal thickening. You can have 1 disc area of retinal thickening, a part of which is within 1 disc diameter from the center of fovea. It just means that the edema is close to the fovea and needs to be treated because it will affect visual acuity. On FFA, you can classify diabetic macular edema, look for focal, diffuse, and ischemic macular edema. Focal is when the leak and the hyperfluorescence is mainly around the microaneurysms, and that is a focal that would require a focal laser treatment. A diffuse macular edema is when all the retinal capillaries leak diffusely in the inner layers. There is a breakdown of the inner blood retinal barrier. Then ischemic macular edema is when the foveal avascular zone is enlarged and irregular in its margin. The normal size would be 500 microns, about 1/3 of the disc area. If it is more than that with irregular margins, it is ischemic. This is when there is a visual acuity which is disproportionate to the fundus findings, and where laser will be deferred. So cystoid macular edema also could appear in diabetic macular edema with a hyperfluorescence in a flower petal pattern on FFA. Is in the outer plexiform layer of the retina, where you can, in OCT also, you can see the corresponding cystoid spaces. This is on FFA. So on the fundus photography, the hard exudates are a good biomarker to diabetic macular edema, which is chronic in nature. The dense foveal exudate would indicate a poor visual prognosis. On OCT, which is the most commonly performed investigation and most important investigation in DME, there are 4 things to be looked for. Number 1 is the basic structural changes, which are 3: the diffuse thickening of the retina with the cystoid spaces and the subretinal fluid. These are the 3 things which you look for, the basic structural changes. Then whether the edema is present in the central 1 mm subfield zone on the end-face heat map. If it is absent, it is non-center involving DME. If it is present, then it's a center involving DME, which you can see the corresponding involvement of the center on the B scan of the OCT as well. So here is a patient with the center, very center not involved. Here this can also be called an arrow sign, where the hard exudates and thickening is fast approaching the fovea. On the other eye, there is center involving macular edema. And the treatment, the third one is the treatment eligibility criteria, the central subfoveal thickness, which we all look for in the, which varies from machine to machine. The Heidelberg Spectralis, it is about 320 micron for men and 305 for women. And Cirrus, it is 305 and 290 in women. In the Zeiss Stratus, it is 250 for both men and women. So based on the central subfoveal thickness, we can decide whether to start treatment. Then the fourth one to be looked for is the vitreomacular interface anomalies, which is vitreomacular adhesion or vitreomacular traction. The vitreous adhesion is important because of the elaboration of VEGF and the retention of VEGF in the posterior vitreous. And that gives rise and keeps the macular edema persistent. And these are the patients who may need surgical management. Depending on the presence of derangement of the retinal inner layers, it's called the derangement of retinal inner layers, which you can see here, the 3 lines indicating the inner nuclear layer, inner plexiform layer junction, and the inner nuclear layer, outer plexiform layer junction. Here, if they are intact, a resolved macular edema or the presence of macular edema, the visual acuity could be good. But when a patient who has derangement of the retinal inner layers, even after resolution of the macular edema, the vision continues to be poor. So this is one of the factors which leads to a poor visual improvement after the VEGFs. There's one more factor, the disruption of external limiting membrane and the ellipsoid zone is the second hyperreflective layer inner to the RPE, and the next hyperreflective layer is supposed to be the ELM. When there is a disruption of these layers, it can lead to poor visual acuity post anti-VEGF injection, even when the CST comes down. And summarizing is the OCT, the diffuse thickening, the cystoid spaces, the subretinal fluid to be looked for, central foveal thickness, whether it is center involving or non-center involving, look at the vitreomacular interface. And then start treating the patient. There are a lot of studies gone in. I'm not going into the details. The latest studies, RISE and RIDE for ranibizumab, the VIVID and VISTA studies showing the importance of aflibercept, then the various DRCRNet protocols and the various ongoing trials. So with that, these are the watchword in treatment of diabetic macular edema, the metabolic control, which is number 1. So you need to keep the HbA1c between 5.5 and 6.5 for better results, and the lipids and the BP to be controlled. So always look at the patient's metabolic parameters whenever they come for a review, and prompt referral to the physician is important. Then consider lasers. First, we start giving them anti-VEGF injections monthly. Then when they do not resolve and there is no contraindication to the lasers, we can consider a grid laser or a focal laser at the end of 24 months, according to the various studies and results, and vitrectomy may be needed for some patients. So in medical management, about glitazones could be avoided. These are some of the tips in managing them. Fenofibrate is supposed to be better than the statins, and AC inhibitors are better started. Patients' lifestyle modifications like exercise and reduction in weight, and smoking to be make the patient understand that it triples the risk of visual loss, and that's important. Counseling a patient is also important. Whenever there's a diffuse leak on the FFA, we can consider grid laser, which is placing laser marks around the away from 500 micron from the center of fovea, around avoiding the papillomacular bundle at about 100 micron size and 100 milliseconds. And the focal laser is aimed at the leaking microaneurysms, and blanching them would be the end point of laser. Then looking at the anti-VEGFs, over time, there has been so many anti-VEGFs have evolved. Bevacizumab, which is a monoclonal antibody to VEGF-A, ranibizumab, which is an antibody fragment to Fc portion to VEGF-A, which has got better binding. Aflibercept, which is a fusion protein, and VEGF trap, it is called. So VEGF-A binds by mistake to aflibercept more than the receptor, and it's 1,000 times more binding capacity than the other VEGFs. And brolucizumab, which is a 26 kilodalton, very small molecule, which can penetrate into deeper layers of the retina. And faricimab, which is a multiple mechanism inhibitor, which inhibits both angiopoietin 2 and VEGF-A. And these are the dosages, 2 mg, ranibizumab 0.5 mg per 0.05 ml, and bevacizumab 1.25, faricimab and brolucizumab 6 milligram. And these are the various studies which have shown the importance of these anti-VEGF agents. The protocol T of the DRCR-NET has compared aflibercept, ranibizumab, and bevacizumab, and found that in patients with initial worse vision than 6/9, aflibercept fares better than the others, but a 2-year final visual outcome is the same with these drugs, especially in patients with very good initial visual acuity. So this is a patient. Yes.
We need to conclude because of time.
Yes, sir. So this is a patient after the 3 injections of bevacizumab has settled in the central foveal thickness. And this is another patient who has got vitreomacular adhesion and has not improved much, 6/18 improving to 6/12. And in patients who do not improve, we could try Ozurdex or fluocinolone acetonide implants at these dosages. So these are the various protocols with which we can, they guide us to treat the center involving and non-center involving diabetic macular edema. So whenever there is no improvement below 250 microns on this central subfoveal thickness, we call it a persistent DME. If there is less than 7-letter improvement, but these patients over time could respond because they could be delayed responders. So the options left for them are to switch drugs, use steroids intravitreally, targeted retinal photocoagulation of the capillary non-perfusion areas in the periphery, and the surgical options. Thank you.
Thank you, Dr. I know this is not a topic that can be done justice in 8 minutes, but you've covered the entire spectrum of DME and its management. Thank you. So just in the interest of time and to be fair to the other speakers,
yes,
I call upon Dr. Anand Rajendran on the topic of, this is a very interesting topic of managing atypical diabetic retinopathy, an approach to not asymmetric, it's atypical diabetic retinopathy, and how do you manage on that? Over to you, Anand.
Thank you, sir. I'd also like to thank TNI, the President, Dr. Kim, and Dr. Rajiv for putting this together. Thank you, Dr. Ramakrishna, for having me here. So let me just share my slides. Are you able to see my screen?
Yes.
Just go to full screen.
And then again, about the time, I just want to.
Yeah, I know that. I'm conscious. Yes.
Thank you.
So, so we all caught in this pandemic of diabetes, and India, unfortunately, has a dubious distinction of being the diabetes capital of the world. And because we're seeing so many cases of diabetes, it's obvious that there's going to be seen higher prevalence of the unusual and atypical cases of diabetic retinopathy. And very often, it is the recognition and the clinical diagnosis which is the most critical step in the management. So these protein presentations can be because of the intrinsic clinical variability in diabetic retinopathy, the systemic diseases, the ocular diseases that affect diabetic retinopathy, and a few other curio pieces. So amongst clinical variability, there can be disc issues. The diabetic papillopathy versus AIO is a raging debate. Fractional diabetic papillopathies, macular vagaries like foveal neovascularization, massive cortical spots, vascular and peripheral abnormalities, and of course, there's always the atypical course that diabetic retinopathy can take. So coming to diabetic papillopathy, Mahesh briefly touched upon this. Well, basically, it's a transient unilateral or bilateral edema seen most often in young patients with good visual acuity and minimal background diabetic retinopathy changes. And essentially, it is the extension of the microangiopathy of diabetic retinopathy that we used talking about onto the optic nerve head. And you need to differentiate it importantly from raised intracranial hypertension, hypertensive retinopathy, and new vessels of the disc. So this is an example of papilledema that you're familiar with. Mahesh also kind of talked about this, and neuroimaging can distinguish this. New vessels of disc is basically, you will see this arborizing network of new vessels emanating from the disc in a crisscross haphazard manner. Fluorescein angiography will show it lighting up. Hypertensive retinopathy will be seen bilaterally, and you'll have a swollen disc, and you'll have this macular star or fan seeping into the fovea, and just a routine BP assessment will show this up. Now, there is a raging debate between diabetic papillopathy versus AIO. Non-arthritic AIO, as we know, is the commonest cause of disc edema in elderly patients, irrespective of whether they're diabetic or not, irrespective. And it's compared to diabetic papillopathy, it's AIO and is associated with greater visual loss, deeper field defects, RAPDs, relative afferent pupillary defects, and sectoral hypoperfusion of the disc on fluorescein angiography. And of course, it's associated with the poorer visual outcome. There is, of course, an overlap in the spectrum of these two diseases, and Hayre actually considered diabetic papillopathy a non-entity, and he considered it actually to be a very, very early form of AION. Now, this is an example showing AION in the upper panels and diabetic papillopathy below. As you can see, a very swollen disc in AION with a crowded disc in the other eye. And this is usually seen in the setting of hypermetropes. So the crowding of the disc predisposes this to this kind of ischemic swelling. Whereas on diabetic papillopathy, you don't really see that pallid swelling, and you see background features of diabetic retinopathy also. Diabetic papillopathy, one thing that can help us differentiate between the two is there can be very often, and is seen clinically, spontaneous resolution with simple control of diabetes itself. For example, a case here, just control of diabetes, and you see the clinical features as well as the angiographic features regress. Now, featureless retina is basically proliferative diabetic retinopathy masquerading as a mild NPDR. There's extensive capillary closure leading to loss of the usual features like cotton spots, earmarks, blood hemorrhages. One clinical clue is the usual presence of white thread-like arterioles. And on the angiogram, you see extensive capillary non-perfusion and new vessels. For example, a case like this, to a casual observer, one might think this is moderate NPDR. But if you look very carefully, there are these white thread-like arterioles, which I was referring to nasally. You can also see these fine new vessels on the disc, which sometimes the casual observation might miss. And when you do the angiogram, you see it's actually a high-risk PDR. Peripheral diabetic retinopathy was shown by Nikki Joel can be seen in 2 to 3% of the cases of DR that we see. Equatorial fibrovascular proliferation can also happen and then lead on to peripheral DRDs, fractional detachments. Oral, far periphery, oral fibrovascular ridges were seen in 50% cases of peripheral PDR in a Japanese study. And one also found choriovitrial neovascularization happening too. So these are just curious cases. Again, what looks again to the casual observer untrained eye as moderate NPDR, if you look only at the posterior pole, then when you look at the periphery, it is actually peripheral PDR. So that's why it behoves us to not just focus only on the posterior pole in diabetic retinopathy, look in the periphery too. Diabetic retinopathy can go off course too. So you can have florid diabetic retinopathy, which is basically very rapidly progressive, very severe PDR in uncontrolled type 1 diabetics usually. And this behoves us to put in extensive PRP and perhaps even early vitrectomy. Spontaneous regression of diabetic retinopathy can also happen. This was seen initially and first reported by Vanderloo with 3 type 1 diabetic women with stable blood sugars, and there was a spontaneous reperfusion of the capillary areas. So a few trivial and curious cases. One can also find foveal new vessels. These are new vessels at the perifoveal ring in long-standing type 1 diabetics and usually associated with PDR. Huge cotton wool spots were first reported by Egger, almost 2 to 4 disc diameters in size, usually associated with the stenosed arteriole leading up to those cotton wool spots and a few collaterals around there. Fractional diabetic papillopathy was first described by the German Peter Kroll. It's basically vitreoretinal fraction on the optic disc, and you have the disc looking pale, and there is reversible visual loss. It's something which can be resolved surgically. So this is a surgical condition. So example of foveal neovascularization here. You see the angiogram clearly shows the neovascularization, the hyperfluorescence in the fovea. Example of vitreopapillary traction. So this is a patient who presented at 6'9" in the eye, and you can see on the OCT there is incipient traction. There's a mild lifting of that optic nerve and peripapillary tissue, and you can see a little diffuse leak on the angiogram on the left. But see, a month later, what happens? Suddenly, there's a lot of hemorrhage, and one would instinctively think that we are talking about proliferative diabetic retinopathy. But if you look carefully, you can see that hemorrhage streaking and funneling into the optic disc, and you can actually see the hemorrhage lining those furrows. So a good slit lamp biomicroscopy examination would show in this case that it's a vitreous funneling into the disc, and on the OCT, it's chalk and cheese. You can see a triangular elevation of the vitreous pulling up that optic nerve had mass tissue. So surgery was done. It's a simple surgery. Just remove the vitreous, and you see everything settles back, and no PRP is done, but all that hemorrhage is gone. Another case of fractional papillopathy, which you can get sometimes with severe asteroid hyalosis, where the vitreous is very sticky. And you can see this was the pre-op picture with 618 and post-op a very clean picture with just the simple vitrectomy. See the OCT too. Vision, good vision can sometimes be seen through vitreous hemorrhage. Another curious case, you see vitreous hemorrhage all around, right here, and you see a little bit of foveal hemorrhage, but this patient has good vision. So this can happen rarely. Systemic diseases can also affect diabetic retinopathy, like hyperlipidemia and carotid occlusive disease. Lipemic retinopathy is when you have high serum lipids, high triglycerides. This is seen in 2% of diabetic retinopathy. It's a milder variant of lipemia retinalis. Looks like coats and statins have been shown to reduce these retinal exudates. And this is an example of a very foreign case of lipemic retinopathy. Carotid occlusive disease can induce an asymmetric retinopathy. So carotid occlusive disease retards diabetic retinopathy. That's what Gay, Rosenbaum, Moss thought earlier. But the fact is that actually it aggravates diabetic retinopathy, and Dugal, Doglu, and Inu were right in calling it out. So, and the hallmark pathology is the ischemia that this occlusive disease confers on the eye. And when that stenosis goes up to 90%, you can even get ocular ischemic syndrome. An example of an asymmetric diabetic retinopathy where you have this massive traction detachment in one eye, all those moderate features in the other. So again, but one must be, and there's another case where severe traction diabetic retinal detachment in the left eye. So the ocular disease can also affect diabetic retinopathy. So myopia, glaucoma, optic atrophy, all these can, these can retard the progression of DR. So myopia, glaucoma, and optic atrophy do so by inducing a metabolic slowdown. They reduce the oxygen demand, this is therefore the VEGF release. Chorioretinal scarring and RP, they destroy the oxygen-hungry photoreceptors, and as we know, the outer retina is largely involved in diabetic retinopathy. And this was actually the start of PRP in for proliferative diabetic retinopathy. Observation by Beetham and Ailo that lesser PDR was seen in cases of RP and chorioretinal scarring. PVD, when that happens, it removes the scaffold for new vessel growth and therefore mitigates the progression of DR. Radiation retinopathy aggravates the ischemia of DR and therefore predisposes to hemorrhage. MACTEL is a disease which is associated with diabetic retinopathy. It's not really a part of the spectrum. That when one sees this swelling in the macular area, one can confuse it with DME, and one needs to be aware of this and sometimes do an angiogram just to rule that out. So asymmetric diabetic retinopathy, what's the diagnostic basis? So the definition given by Dobru is PDR in one eye and NPDR in to rule out ocular factors, featureless retina, peripheral PDR, carotid insufficiency, and then rarely you may get this kind of a natural asymmetry in 5 to 10% of cases. So is this asymmetric diabetic retinopathy? It looks like vitreous hemorrhage in the other eye, and what looks like mild, non-NPDR in the other eye. But then look at that. There is a little bit of a small USL complex right there, and the angiogram shows that there's a lot of peripheral devascularization. So one has to be careful before branding cases asymmetric DR2. Then another case which I'll quickly go through, this is a case which stumped us, so severe NPDR with CSCR. You can see the serous detachment, a small PED, some fibrin out there, and this patient was given anti-VEGF Avastin, and you see the background is severe NPDR, and the serous detachment went down. But note that the fibrinous component is actually increasing. And it increased again a month later to the point where there was a massive amount. And then with the angiogram, and found this actually a case of CSCR in severe NPDR. And this was that what is known as diffuse retinal pigment epitheliopathy of CSCR. We offered PDT, patient didn't take it. Then finally, when it worsens again later, 1.5 months later, PDT was eventually done, and you find that that coagulum just vanishes, melts away, and vision improves. This is just a sequence of cases as the fibrin increased, and then we did PDT, and you see that remarkable resolution. So PDR can also be complicated by hematological diseases, by neoplasia, CML, and if we had a patient who came in with a sudden loss of vision over a day, and he had no other systemic illness or trauma, and you find this white, vitreous hemorrhage, white-centered hemorrhages, florid picture in one eye, and then a milder picture, but a lot of spread out white-centered hemorrhages in the other eye. Another case where you see a PDR, a patient came in like this, and within weeks accelerated to a florid, massive vitreous encephalitis hemorrhage, just because there was CML detected on blood testing. So in summary, diabetic retinopathy is a protein disease with varied manifestations, and it behoves us to understand and recognize these because it improves our diagnostic capability in terms of recognizing featureless retina, diabetic papillopathy, asymmetric DR, and also behoves us to modify medical treatment where it's indicated, like ERP, as I mentioned, PDT in that CSCR case, lipemic DR, using statins, also early surgical treatment as an equatorial fibrovascular proliferation and fractional papillopathy. Importantly, also avoiding excess futile treatment as in diabetic papillopathy MACTEL, and where indicated, importantly, instituting early aggressive treatment as in PDA. Thank you.
Thanks, Dr. Anand. It was really very good talk, and I think each one of you should know these atypical presentations, which many times we see in our clinic. And they are so important to recognize these. And as he rightly mentioned, many of them, the management changes. Only one point which I had about your tractional papillopathy, though your case was a non-proliferative, but majority of them, the moment you see these vitreous abnormality, it's usually associated with the proliferative diabetic retinopathy, because that's really confusing. That when you have a vitreous hemorrhage, you have a tractional papillopathy, you have features of moderate NPDR. So sometimes you may think that it's the NVD which has fibrosed and caused it. And your case, you didn't do a PRP, but now it's good idea to actually do an angiogram later on, because I would suggest that the majority of them have PDR actually.
Yeah, actually, I have a couple of cases where, at least more than a couple, where we have absolute moderate, and I'm talking of both eyes also. So there was another case which I presented at one of the imaging meetings, where both eyes sequentially had tractional papillopathy. So I mean, when you have PDR and you expect that traction, you'd probably have traction on the disc and also in extra macular, if not macular traction, in extra retinal area, extra macular areas too. So that would give you an insight. But the issue comes when there is no other traction elsewhere and it's right on this. So that's where it's isolated, whichever track.
Thanks. So we'll go to the next talk, and I would request Dr. Ashish, and I think none other than him can talk that topic very well. What is the novel things which are happening in diabetic retinopathy management? Dr. Ashish, please.
Thank you, Dr. Kim and Dr. Ramakrishnan, sir. And thank you so much for having me here and making me a part of this, giving me this opportunity. And it's an extremely, I'm extremely honored to be a part of this wonderful group of clinicians here. And wonderful talks initially by Dr. Mohan Rajan, Anandi, and dear friends. So Anandi has covered, few points. So I would not take much time. So we have been trying to understand these new molecules. That is one of our favorite areas since last 2 to 3 years. So I was be little bit in detail what Anandi had just tapped upon. So these are my disclosures before I proceed further. So realistically, if you really look at, what kind of molecules that we are looking forward in probably in a couple of years or so, is faricimab, which is known as Vabysmo in United States and Europe. India has not yet approved, but probably we would get it maybe in a year or so. Brolucizumab, known as Pagenex port delivery system, again approved as Susvimo in United States. High dose Eylea. So probably these are the realistic candidates that we can look upon as far as newer therapy of diabetic macular edema is concerned. We were excited in 2020 when faricimab was in making, and if you really see, faricimab is the only molecule till now which has realistic dual mechanism. Anandi said that in terms of the receptors, that Ang2 is definitely an important receptor to look upon, especially Dr. Rajiv has also done a lot of work on diabetic retinopathy, so he would certainly agree with me that kind of Ang2 might have a role on the endothelium or the vessel stabilization. Probably anti-VEGF alone might not have done that. We would see that because we have modalities like OCT angio now, where we can realistically see that whether vessel wall is being maturated or not. Different than the aflibercept molecule. Predominantly, most of the newer molecules, we are encountering some of the inflammation issues. But in faricimab, if you really see the FC segment, which is called an inflammatory segment, it is modified. It is modified in a way so that it reduces the immunogenicity. Although aflibercept was also targeting not only anti-VEGF as a factor, but also PLGF also. But realistically, it was not a molecule which had dual target. But faricimab is the first molecule with realistic dual target on the different arms. Faricimab is another interesting point with faricimab is that very interesting clinical trial design. We loved it. That's why, we just published this part. So saying that, you should have this kind of clinical trial designs over the time when we have newer and newer therapies coming in, because these are the trial designs which might be more similar to what we practice in day-to-day manner, because you can have a shift from 1 month to 4 months. So that kind of a dynamic change that we see so these are preferred. Brolucizumab, we know when this molecule was in making, we were excited, and we did publish that it could be structural, a structural revolution, because if you really see all the molecules from large molecular antibodies, everything in my mind was a bio better, because if you look at bevacizumab, aflibercept, although aflibercept had a little bit of innovation in terms of the VEGF1 and 2 receptors, and further ranibizumab was a clear-cut bio better because it just didn't have the FC arm, so it was easy. But if you really see, brolucizumab has no constant portion. It is 2 variable portions which are just linked with a protein chain. Amazing. If you really look at the structure, structure-wise, this is the only molecule, means this is not only ophthalmology or retina, in the entire medicine, this is the smallest molecule which we ever had. But probably that's the reason that it had paid its little bit of price in terms of safety. So this is approved in the United States for DME as well, but means unfortunately some of the safety issues cropped up which nobody could understand till now. Means we have proposed mechanism from our end, but still there is no way that you could understand why this molecule causes this kind of inflammatory issue, and whether there was no straight line that you really track. Means we did our homework, we did produce some of our workflows that can mitigate the safety part whenever somebody encounters, but still means we do not know means how this pans out in DME, although company is saying that they would be having this in DME in near future. Port delivery system. Port delivery system means we have always, all of us have dreamed of something which could, enhance the delivery system, which could reduce patients' visits. So this was designed, and I think I would say, it's again a miracle. Means although it has its own share of troubles, but it still means any innovation we need to respect, because ultimately a lot of R&D goes in, and that's how things start. So this is being under trial in DME also. And initially when it started, the journey was a lot of vitreous hemorrhage patients were there. Almost 50% of cases had vitreous hemorrhage in trial. And over the time, then the technique was changed, and even vitreoretinal surgeons, they need to get trained to really do it right. And after that technique, it has come down to 5% now. Unfortunately, there's a voluntary recall of this implant in the United States now, but means we should not think that it's not going to come back, because there is a septum which requires a refilling. That septum is a quality issue. So it's means from a responsible company, they have taken this call and they have stopped all the replantations, whether it's a clinical trial or patients who are already on there. Means a lot of nuances that you need to see for this drug, but we look forward that it comes back. Means this, I would say, had great results which were recently presented at American Academy with high dose 8 milligram Eylea. So means probably the goal is over the time is that more and more we can extend, that would be better. So probably high dose Eylea, which has shown excellent results, might again extend the interval till 4 months. If you really want to know that what other targets are, so this is an extensive list. I'm not going to detail in the interest of time. So new clinical approaches also. This is the work that we have done around a couple of years before. Now we are just trying to validate it, that in cases where you have subfoveal neuroretinal detachment and the intraretinal edema, you can just treat them till the subfoveal neurosensory detachment flattens, because after that, in our experience, they do not improve, but still it needs to be validated. So means I would like to say thank you so much for involving us here, and means I would be happy to answer if anybody has any questions.
Thank you, Dr. Ashish. I think nobody could do justice to this talk better than you. So it was a wonderful presentation. Just a quick single question on the Faricimab. What are the chances, and how soon do you think India is likely to get it?
Sir, Faricimab, I think what I have heard from the company is that they have already started recruiting. Almost 2-3 people are recruited. Now, DCGI has to take a call whether they want to have a phase 4 for this before they approve it. So I think there is a talk of phase 4, but I do not think that it would be very soon. Means probably I would say it would take at least 1.5 years to 2 years.
Thank you, Ashish. I wish we could open
Well done, Ashish.
more questions.
Very nice. Very nice.
Very nice.
Thank you.
Nice presentation.
Thank you, Ashish.
Thank you, sir.
Now I'll call the next speaker, Dr. Syed from Tirunelveli. Another very, very important topic on imaging in diabetic retinopathy. Today that has changed how we manage diabetic retinopathy. So over to you, Dr. Syed.
Thank you, sir. And also I thank TNOA for giving me this opportunity. It's an important topic, but most of our previous speakers has covered most of the things. Though clinical examination with a dilated fundus examination, slit-lamp 90D and IO is a gold standard in diagnosing diabetic retinopathy. Various retinal imaging techniques have helped us in not only diagnosing the disease, but also in prognosticating the disease in a better manner. So fundus photography is one common technique which everybody uses, and it's a time tested in many clinical research. And it's able to identify, we are able to identify most of the retinal lesions with the fundus photography. And it is one of the basic technology which is used to grade the severity of diabetic retinopathy in most of the clinical studies. The standard sound field photograph is being used to grade the severity of the disease in all like ATDR study and all. And it is also helpful in monitoring the improvement or progression of diabetic retinopathy over time. Besides, is another important advantage is counseling and educating the patient about the disease. Whenever you show a patient about the hemorrhages inside the eye, they will be like much more compliant and they will stick to your treatment protocol. So it is a one important tool to educate the patient in a better manner. And it needs a minimal training only. And standardized fundus photograph, newer fundus photograph can capture up to 55 degrees of images. That includes disc and macula. And the greater limitation is sometimes you will get an image artifact like this, and the image quality can be reduced whenever you have a video of like cataract or vitreous hemorrhage, and limited field of view, less than 60% of retina is visible in standard photograph. So we can steer the images in multiple quadrants, and we can have a 75-degree field of view with and we can create a montage image which can include optic disc macula, vascular updates in the temporal macula. And the disadvantage of montage is you can have some shadows at the boundaries where the images overlap, and that area one can miss some important findings. So to overcome this, we have ultra-wide field photography. We have a lot of cameras like the Claros and the Optos, which can give about 133-degree field or even 200-degree field with this. And we can advantages is we can visualize most of the peripheral retina in a minimally invasive fashion at a shorter resolution time. And this also found that there is an increased identification of DR and vision-threatening DR compared to non-magnetic fundus photography with ultra-wide field imaging. And the patients who have predominant peripheral lesion had an increased risk of DR progression over 4 years. Only disadvantage is there is a distortion of images because of the spherical nature of the globe. And we have a lot of artifacts like eyelash artifact, and there is a false color representation of fundus findings with this image. And another important feature is like a high equipment cost. That is one disadvantage of this image. The other technology like a fundus fluorescent angiography, which complements the fundus photography, and it plays a very important role in visualizing the retinal vasculature. It's a gold standard in evaluating the retinal vasculature. It also helps us in staging the diabetic retinopathy and visualization of neovascularization and areas of capillary non-perfusion, ear mass, and microneedling as well. Besides, it's also helpful in identifying macular ischemia, that is, which is identified by the presence of enlarged foveal elastic zone. And in CSME, it helps us in differentiating between diffuse leakage and focal leakage, and it also helps us to identify where we have to give laser treatment. Whereas in patients with unexplained visual loss, we can identify macular ischemia, which is identified by enlarged foveal avascular zone. And in patient with, it's also very important the technology to identify the capillary non-perfusion areas. And in patient with obscure neovascularization, FFA helps us to identify the neovascularization in a better manner, so that we can diagnose the disease in a better manner. Conventional angiogram, like a fundus photo, just like fundus photo, they will capture up to 55 degrees of image, and we can also create a montage image. But the problem is these images are taken at a different time interval, so we can miss some features. So we have wide field angio, which can give about 1 or 2 degrees in case of Heidelberg, and we have a 200 degree of field in case of optos imaging. And just like a wide field fundus photo, the ultra-wide field imaging helps us to identify more than 3 or 4 times non-perfusion and 2 times more NVE and 10 times more retinal pathology with the help of wide field angio. Besides this, it also helps us to identify the peripheral neovascularization. as I told Anand sir also. And it's also helps us to target our photoaggregation for PDR and DMA management. Though it gives us a lot of depth of information about the disease, FFA has some limitations, like because it's an invasive technology and it requires an experienced photographer, and timing is very critical. If you imagine if timing is missed, then some crucial findings can be missed. And another drawback is it has a limited depth resolution. That is, we cannot distinguish between superficial and deeper vascular fractures, and it is contraindicated in patients with renal disease and pregnancies and drug allergies. Other technology which is used is ultrasound. That is, it is used in hazy media when patient have a hemorrhage or a cataract. It helps us to identify the status of underlying retina in a better manner, and we can identify whether there is any vitreous interface separation or detachment is present or not. And it also helps us to chart. Sorry. It also helps us to chart the surgical plan prior to vitreous surgical intervention. And another important investigative model is OCT, which helps us to, it's a non-contact, non-invasive technology, which is capable of capturing high resolution image. It almost gives image almost similar to histopathological section. So it is also known as optical biopsy. And it also helps us to quantify the retinal and intraretinal thickness in a better manner. In diabetic retinopathy, it's now the gold standard to in the treatment of diabetic macular edema. It's the slit lamp examination and stereoscopic fundus photo are subjective, whereas this is very quantitative. It can do a quantitative and qualitative reproducible technology to assess the macular edema, and it's currently the most gold standard technique. And it helps us in classifying the diabetic macular edema in diffuse retinal thickening or cystoid macular edema, or we can identify the presence of serous retinal detachment or subretinal fluid, or north posterior hyaloid and rational macular edema. This classification helps us to plan our treatment protocol. So if there is a center involved in diabetic macular edema, we can go ahead with anti-VEGFs or parenteral therapy, whereas in non-center involved in diabetic macular edema, we can go ahead with laser. And OCT also helps us in differentiating between the cases which require medical management or surgical management. Besides, it helps us to follow up the patients and to educate the patient in a better manner whether our treatment is working up or not. Besides, it helps us to give the prognostic factors like drill, which is described already, and presence of hyperfoci or other intraretinal cystoid spaces or bridging retinal processes. All this helps us to prognosticate the patient in a better manner. The limitations of OCT is the cost of equipment and limitations for media opacity, and we need a skilled operator to capture, and it is difficult to capture images in patient who cannot fix it, and we have some artifacts to do automatic software errors also. And another important investigation is OCTA, which is a non-invasive technique which can visualize the microvasculature of retina and choroid without a need for any dye. And it can be performed along with our routine OCT examination. And in addition to that, we have a structural images also accurate, so we can have a direct correlation between retinal OCT scan and OCT angiogram. And another advantage is the images are depth resolved. So we can visualize both the superficial and deep capillary plexus in a better manner. And in OCTA, the microneedle appears as a focal dilated saccular or fusiform capillaries, and whereas CMP appears as a region with no or sparse capillaries. And it also helps us to better identify neovascularization and the disc and other areas because it is not affected by leakage as in FFA. Besides, the macular ischemia can be well picked up by the OCTA, where it shows the larger foveal avascular zone and irregular foveal avascular zone with the greater vessel caliber and with a lower vascular density and all. And it is also found that the horizontal foveal avascular zone diameter is also significantly larger in patients with DR compared to healthy controls. The limitations of OCTA is it does not demonstrate leakage, and the field of view is very limited. Though we have now recent like montage OCT can also be taken, OCTA can also be taken, but the field of view is far less compared to the ultraviolet field angiography. And image artifacts like projection artifacts or movement artifacts can also affect the quality of images. Besides, we have a lot of new technologies like non-mutative fundus photography, which is low cost, which helps us to, so they are portable, they can be taken to various places so that it helps us in doing a telescreening, like it can be taken to the patient's doorstep, and in a diabetologist clinic also it can be picked up, and it helps very much in the telescreening technology. And another thing is now recently smartphone photographs also very useful in taking fundus photograph, and it paid a new array of like you can use it along with the artificial intelligence to grade the diabetic retinopathy in a better manner. So to conclude, like to summarize, we have a lot of new technologies which helps us to precisely give a treatment and monitoring DR with the goal of improving visual outcomes in patients with the diabetes in a better manner, along with a better clinical examination. Thank you for the opportunity. Thank you.
Thank you, sir. Really very good talk. And I think you covered all the imaging modalities. And as you rightly said, so many new advances have happened. We need to be aware, use these multimodal imaging at the right time, right way. A lot of information we can get. I think we are little short of time. We'll go with our debate. And no, Dr. Kim, sir, anybody wants to add anything, please?
I think we'll finish the debate and then, we can debate everything.
So it's a very interesting debate. We have a topic on laser pan-retinal photocoagulation versus anti-VEGF in proliferative diabetic retinopathy. And for laser, we have Dr. Deepak Arthur and Dr. Tenarasu talking about anti-VEGF. So we'll first start with laser PRP. Dr. Deepak.
Good evening, sir.
Yeah.
Good evening, everyone. Am I audible?
Yeah.
I'll just share my screen.
Deepak, you have less than 5 minutes to.
Yes, sir. Yes, sir. Yes.
To the argument.
Yes, sir. Okay. Is my screen visible?
Yes.
Yes. Okay. Good evening, everyone. I really thank the organizers and the governing body and the president of TNOA for giving me this wonderful opportunity. So today's topic is going to be, is it PRP or intravitreal injections for the management of proliferative diabetic retinopathy? Yeah. So at the outset, I would like to say that I'm going to talk about the use of PRP as the primary therapy for PDR. And it is going to be irrespective of the macular status. So why laser and why not injections is what we will be discussing over the next few slides. A small review at the basic pathology of proliferative diabetic retinopathy. We all know that there is microangiopathy leading on to microvascular occlusions, and that in turn leads to retinal ischemia. Retinal ischemia here is the basic pathology which gives out a lot of angiogenic and pro-inflammatory mediators leading to neovascularization. So unless we knock off the actual root cause, we are not going to really treat the disease as such. So looking at the different scientific basis of the treatment modalities, we have the classic studies, right from the DRS to the ETDRS, which have, without any doubt, established the definitive reduction in severe visual loss following the pan-retinal photocoagulation. And the long-term effectiveness of PRP has also been very well established, and it is safe as well. Newer studies have come up, like the DRCR-NET protocol S, where they have tried to compare PRP versus intravitreal injections, not just one injection, but serial injections of ranibizumab. And again, we have the Clarity study where they have tried to compare PRP versus injection aflibercept, again, serial injections. And they have just tried to show that probably it is as good as PRP because PRP is already a gold standard. People have just done a non-inferiority study and they've just tried to compare it and say, probably these are as good as PRP. So, but why would I want PRP over injections? So here the basic pathology, as I said, ischemia, retinal ischemia, that gets addressed. It reduces the load of peripheral ischemia and the consequences of hypoxia are totally reduced. So there is no impetus for neovascularization. So it's a one-time management and the basic pathology gets addressed. And it's a definitive solution as well. PRP can be performed in around 1 to 3 sittings and that's it. Maybe rarely you would need to give an add-on laser later on, but with those 3 sittings, we have just completed the treatment for that patient. So it's certainly a definitive solution. Non-invasive, certainly non-invasive, compared to injections where we'll have to do multiple invasive procedures, few monthly intervals, And it certainly, laser certainly does not have that complication of being invasive. It's a non-invasive. Cost factor. This is something that really has to be considered, especially in our Indian setup. The majority of our patients are from either the middle class or even the lower middle. Cost effectiveness has to be really considered. Pan-retinal photocoagulation. I can finish the entire PRP for a cost of around 2,000 rupees. But imagine the cost of injecting a patient every few months. That too, think of aflibercept, think of ranibizumab. Each would cost around 30 to 50,000 per injection. Asking somebody to get injected every 3 months with that amount of cost, is it really practical? And is it worth it? Patient compliance. Obviously, 2 sittings of laser. Patient would be happy to come for that. Tell them every 3 months keep coming for injections. I don't think patient will be very happy to do that. And again, cost, as we previously spoke about, nobody would want to keep spending 30,000 or 50,000 every 3 months. Patients are not going to come to you. They're going to run away. Infrastructure requirement. Laser machine, it's a mobile machine. It can be transported. It can be taken everywhere. And you can see this picture. This is a mobile van called the Nayantara project. That is by the government, where this machine goes around to all the peripheral areas giving PRP to the patients. So it's very portable and it could be taken to even rural setups. But the infrastructure required for administration of an injection, we all know the cold chain has to be maintained. The sterile precautions have to be maintained, allocating the injections, especially if you're going to give bevacizumab, and all those things have to be really followed. So practical difficulties are there. PRP as such is a much easier procedure. And the newer studies, especially Protocol S and Clarity, have said that the initial 2-year results said that vision loss is actually less when you give injections. But looking at the 5-year results, you see that the amount of visual loss almost becomes equal in both the arms. So it's not really that effective with injections. Anti-VEGF related complications, both systemic and ocular complications are there. As we know, several complications are there, especially the dreaded complication being endophthalmitis, this being an invasive procedure. So that can always be avoided in PRP. And yeah, there's something called the Scrunch syndrome. It's a rare one, but yeah, again, in those with advanced disease where there is excessive fibrovascular proliferation, injections can worsen, laser can worsen and cause a tractional retinal detachment. Laser also does have that, but a carefully done laser avoiding the fibrovascular proliferations can help us in this situation. So these are the several systemic complications, which I'm not going to detail. And again, safe in pregnancy, especially women with gestational worsening of diabetes mellitus, worsening of proliferative retinopathy. Even I personally have lasered so many pregnant women with PDR. It's safe, and there has been no proven study about the safety profile of intravitreal injections, anti-VEGF agents in pregnancy. So PRP is certainly safer. And maybe anti-VEGF, I would like to probably add it as an adjunct to PRP in some cases, that to not all cases, maybe in cases where there's an associated center involving DME, or if there's a neovascular glaucoma. And as discussed earlier, if I'm planning a cataract surgery, I would like to do laser after that. Maybe as a short-term measure, I can probably add on an anti-VEGF, and certainly not as the primary method. So PRP is always, in my opinion, the best treatment, primary treatment for PDR, because to summarize, it's effective and dependable. It is safe. The safety profile is certainly much better. It's affordable. It's a lasting solution, and it's easily accessible. Thank you very much.
Thank you, Deepak. I think Tennarasu, it's up to you to defend. Go ahead with your slides. You're muted, Tennarasu.
Thank you, sir. Thank you for the wonderful opportunity. Am I audible?
Yes, yes, you are.
My slides are visible, sir?
Yes.
So I'll be debating in favor of anti-VEGF in PDR. So as we all know that around 1.5 adults of diabetes have PDR. In DRS, they have found out that more than 50% of PDR with high-risk characteristics, without treatment, they will have a vision loss. So definitely they need treatment. So what kind of treatment? So if you look at this algorithm, hypoxia causes, the center of attraction is VEGF. So why don't you target the VEGF directly and knock it off, and then arrest all the factors? So to support this, I need to take up into few studies. So if you look into the DRCR-NET Protocol S, So they have two arms, ranibizumab versus PRP. Ranibizumab, they have given every 4 weeks for 12 weeks. And the outcome they have around, there is increase of plus 2.8 letters in cases of ranibizumab compared to only 0.2 increase in the letters in PRP case. But if you see the quiescent PDR after the treatment, there is no significant difference between the two groups. Even with the ranibizumab as well as laser, the percentage of quiescent PDR at the end, it's almost same. But when you see around only 6% of the cases require rescue PRP in those cases of injection, whereas in those cases of laser who underwent complete resettings, 45% needed supplemental PRP. So out of which, if you look at the injection group, 9% developed visually significant DME. All these cases did not have DME prior, but if you look at the PRP group, 28% developed definitely visually significant DME. Out of the 155 group, number of eyes, 62 eyes required injection post PRP. So if you calculate the cost factor, definitely the post PRP as well, they definitely needed anti-VEGF injection. So the cost factor nullifies here. So if you look at the progression of PDR, 32% has the progression in the cases of ranibizumab, whereas in PRP it's 44%. Though it is not visually significant, injection ranibizumab is not inferior to the PRP. And again, those cases of injection only had less vitrectomies, whereas PRP during follow-up, the more number of cases went for vitrectomies. Again, there is one more study, it's a Clarity. They have compared aflibercept monthly 3 doses versus PRP standard 3 settings. Again, their BCVA is non-inferior to PRP. There is definitely a plus 3.9 increase in the ETDRS letters compared to the PRP. Definitely, it is visually significant. ETDRS has graded a diabetic retinopathy severity grading. So according to this, the aflibercept group has a better DRSS grading compared to the PRP. It means that the worsening is very less in the aflibercept group compared to the laser group. So if you look at the DME at the end of 2 years, only 11% of the aflibercept group had DME, whereas in the PRP group, there is 29%. It's a marked increase. Comparatively, it's very significant. And out of which the vitreous hemorrhage patients, it's only who required vitrectomy, it's around 9% in cases of aflibercept, whereas it is 18%, double the amount in cases of PRP. So again, if you look at this, these patients definitely require the cost of surgery will be much more. So again, the cost factor nullifies here. So if you look at the regression of neovascularization, at the end of 2 years, there is not much significance between the two groups. So 81% in the aflibercept and 78%, which says it's both are equally important. So if you look at the total regression of neovascularization, 64% had a total regression at the end of 2 years, whereas only 34% had in the PRP, which means all these patients require either add-on PRP or anti-VEGF following or vitrectomies. So this is another study which is not directly compared in the cases of PDR, but it is mainly studied for DME. But subgroup analysis, they have graded that DRSS, that is diabetes severity grading. If you look at that, in the ranibizumab group, there is improvement of around 35 to 38% of severity grading, whereas only in the sham group, very less. So it signifies that definitely anti-VEGF has role in downgrading the retinopathy severity. Again, it helps in arresting the progression of diabetic retinopathy. Again, if you look at the PDR development, only 1.6 to 5.6% developed PDR in this anti-VEGF group, whereas in the sham group, if you look at it, it's 11.5 to 15%, which is definitely significant. So protocol C, again, it is not directly for PDR, it is for DME. Again, they signified that there is definite improvement in the development of PDR, which is definitely there is a significant, visually significant. And whereas again, DRSS definitely showed in NPDR eyes. So they have very significant downgrading of the severity. So this is an upcoming ongoing phase 3 trial. This is a data collection, which again clearly states that anti-VEGF has definite role and development of PDR is very, very less compared to the sham group. Again, the neovascularization of iris is very, very less in the aflibercept group compared to the sham group. These all supports in favor of anti-VEGF. So what are the definitive indications of anti-VEGF treatment for PDR? Neovascular glaucoma, yes, definitely anti-VEGF has a complete role. So if you look at all these studies, that one single dose of bevacizumab has complete almost 69% had a regression within the 3 weeks. Whereas in the even if you look at the patients who underwent glaucoma drainage devices, those who underwent anti-VEGF less complications, and they have good success rate and good IOP control. This again favors in favor of anti-VEGF. So if you give anti-VEGF at the stage of open angle, especially intracameral anti-VEGF, definitely they have a good improvement. So again, in cases of vitreous hemorrhage, what kind of vitreous hemorrhages? Definitely those patients whose fundus is very difficult because of the vitreous hemorrhage. So you can go ahead with the anti-VEGF. There is no any traction. You can confirm it with an ultrasound. So following which, once the vitreous hemorrhage resolves, you can do the management with the PRP. Again, anti-VEGF has a role in this. So anti-VEGF again helps in clearing the vitreous. It reduces the need for vitrectomy in the future. So again, anti-VEGF can be given in the cases of post-vitrectomy, recurrent vitreous hemorrhages. Anti-VEGF has a definite role. So again, this is very important. Preoperatively, surgical adjunctive treatment, anti-VEGF is very, very important because it reduces the intraoperative bleeding. It reduces the number of diathermy done during the surgery, and even it reduces the number of time taken for the surgery as well. And again, if you look at the Cochrane review, the rate of post-operative vitreous hemorrhage is very, very less in the cases where they give preoperative anti-VEGF. So as we all know that PDR and DME coexist. So definitely if you do an PRP, there is a definite exacerbation of macular edema following PRP. So these cases definitely need anti-VEGF. So again, these diabetic retinopathy clinical network has emphasized that ranibizumab reduces this exacerbation of DME if you give anti-VEGF along with the PRP. So again, there are few cases where in spite of complete PRP, there are few cases where there will be active persistent NVD. So these small studies which have significantly mentioned that there is even after PRP, if there is a persistent NVE and NVD, single dose of bevacizumab within a period of 1 month and 3 months.
Then also you have to summarize. You're overshooting your time.
Yes, sir.
So debate.
Definitely, if you look at the side effects of PRP, definitely PRP is painful and it causes definitely permanent loss of peripheral vision. The patient might have night vision difficulties. Sometimes in renal failure patients, the patient might develop exudative uveal effusions. There will be worsening of macular edema, and accidentally there can be foveal burns as well. These can be avoided. But there are certain situations where PRP is not definitely possible, especially in a case of media hairs with a dense cataract. You can, if it is a high risk PDR, you can go ahead with a preoperative anti-VEGF, go ahead with a cataract surgery, following which you can do PRP. Again, in a case of neovascular glaucoma, there is a corneal edema. You can give an intracameral and intravitreal anti-VEGF, reduce the IOP to some extent, and then go ahead with a PRP. Definitely it has a role. So this is all the definitive indications. Preoperative before vitrectomy, neovascular glaucoma, PDR with DME, media hairs cases, post-vitrectomy rebleed, and post-PRP non-regression of neovascularization. But there are new trials which DRCR Protocol W, Panorama Study, PRIDE, these are ongoing studies. Definitely they will give a definite shift in the paradigm for anti-VEGF. And having said that, combination treatment is always the goal. So we have to look into each patient, patient by patient, and accordingly we need to decide. Definitely PRP along with anti-VEGF has an advantage. Thank you.
Kim?
Yeah.
Yeah.
Thank you. Then that was a, I mean, extensive presentation and argument for anti-VEGF. Both of them have presented. Rajiv, over to you.
No, beautifully presented, and I would like the view of Dr. Madan Gopal. What you feel, PDR, what we should do. So decision maker would be Sriram and Madan Gopal.
Thank you, sir. All nice arguments on both the sides. Wonderful to hear both the scientific arguments, I would say.
Yeah.
But of late, though we are tilting towards a little more anti-VEGF, as Dr. Deepak Arthur has mentioned, PRP would still be the primary role, I feel, because it's giving a more definitive treatment. Having said that, there are indications for giving anti-VEGF agents in select cases.
Rajiv, I think Dr. Tenarasu made the job very easy for us. His
Yeah.
final few slides were actually the conclusion of the debate. Combination therapy is a way to go. I think the next debate shouldn't be on whether you should do a PRP or do anti-VEGF. I think it should be where you will do only PRP and where you will do a combination therapy. I think these days when we see patients, that is what we are trying to decide. Do I only do a PRP or should I go for a combination therapy? That is what we are trying to decide when we see patients, rather than thinking of either this alone or that alone.
Yeah, correct.
Okay.
I hope Kim sir agrees with me.
Yes, yes, I totally agree.
I think that's a conclusion of the debate. PRP, yes, selected, actually, to put it more clear, selected patients will be PRP alone, and a lot of other patients would be combination therapy. That's how the thinking is going these days.
I totally agree.
Okay.
Yeah, I think very clear in today's scenario with our kind of situation, environment, economics. I think laser is the first choice in this, and of course the combination treatment in select cases. Yes, Sriram.
Just to add one point. So the only problem with anti-VEGF in PDR is, other than all what they said, is it gives you a false sense of security. There is PRP and there is PRP. Even in those Clarity and Protocol S, if you look at it, there were at least 30 to 40% of patients who had active new vessels in spite of receiving 3-4 sittings of PRP and multiple injections of anti-VEGF. So nothing is going to substitute a properly done PRP, not even combination therapy.
What you said is correct. And even 5-year, what they found is that though initially they feel the field loss was less, but later they found
anti-VEGF catches up. Anti-VEGF
Yeah,
catches up.
So even with anti-VEGF, field loss is there because the retinopathy progresses, the ischemic areas still continue to progress. So I think that is something you need to, so what you said, a good done PRP is the best one. This I'm talking about, not the cases which he told pre-surgery. Those definitely have got an added advantage. But simple, non-tractional proliferative diabetic retinopathy, I think PRP still scores.
The golden standard.
With macular edema, definitely you'd like to do. And when you have vitreous hemorrhage and when you have media haze, just be sure there is no traction, then only go ahead with anti-VEGF. Don't just blindly give it. Yeah.
With laser, you also have an endpoint in most of the cases, unlike in injections where there really is no endpoint where you stop seeing these patients or so as of now, I think laser is the way to go along with combination treatment. So in the interest of time, I want to thank every one of you. I know all of you are waiting to get over. I'm sorry that we had to, I mean, it got extended in the interest, the interesting discussions happening. I want to thank every one of the speakers here, and of course the entire TNOA EC team for giving us this opportunity to share on this very important World Diabetic Day. Thank you. Over to you, sir.
Thank you, Dr. Kim and the speakers and panelists. Really, it's a wonderful webinar. So many things we have learned. Thank you once again. And I have one announcement. We have 3 more programs for this month. One is a very exciting program on cornea, management of herpes simplex and herpes zoster infection by one of the topmost cornea person from Ilse Hospital, Dr. Chris, will be giving a talk on 25th Friday. Dr. Prajna will be convening the session. And second, because 17th of this month is the World Prematurity Day. So we thought we can have a session on ROP. So Dr. Sriram Gopal and Parag is coordinating, and we will let you know the date. And another third event is the ARC meeting at the Tanjavur on 27th, this on Sunday. Okay, with this, I request my AIC chairman, Dr. Atik, to propose vote of thanks.
Thank you so much, sir. I'd like to thank our President Ramakrishnan, sir, for having come up with the concept of this World Diabetic Day program. Special thanks to Kim, sir, for having put up this wonderful schedule and selecting very good speakers. Thanks to Rajiv, sir, for having wonderfully moderated the session. Thanks to all the panelists. A special thanks to our speakers, Mohan Rajan, sir, Mahesh Kumar, sir, Anandi, madam. Ashish sir, Anand sir, and Dr. Syed sir. Thanks to our speakers in the debate, Dr. Deepak and Dr. Tennarasu. Special thanks to team Milmet for having sponsored the session, and thanks to Numerotech for having given the technical support. Thank you so much. Until next time, bye-bye.
Thank you. Thank you very much. Yeah.
Thank you, Atik, for the vote of
Bye. Good night.
Good night.
Thank you. Thank you.
Ramakrishnan sir. Bye. Good night.
Bye.
Thank you, sir. Thank you so much.
Thank you.
Thank you.
Thank you. Yeah. Thank you, Kim. Thank you,
Thank you, sir.
everybody. Okay, thank you. Bye.